it seems there are some issues with the audio
Although it's a
visual system. So there is always a question as to why some of the sessions are kept last. So કોઈએ કીધું કે ભાઈ દિગંતભાઈ નું હતું એટલે બધા બેઠા છે, કોઈ કીધું કે સતીશ સર તમારું છે એટલે બધા મોડે સુધી બેસે એટલે છેલ્લું રાખ્યું. I think Ahmedabad team is very smart with Chetanbhai and Manishbhai at the helm of affairs. એમને થયું કે આ બધી HLH ની વાતો કરીને લેપ્ટો ને બ્રુસેલા અને આ બધું નોન ઇન્ફેક્શિયસ, પણ આવતીકાલે શું કરવાનું છે? ટુમોરો મોર્નિંગ વોટ આર યુ ગોઈંગ ટુ સી? આખો દિવસ રેસ્પિરેટરી ઇન્ફેક્શન્સ. સો ટુ નો કીપ અસ ગ્રાઉન્ડેડ કે ભાઈ આ બધું બરાબર, 2 દિવસ બહુ બધું હેવી થઈ ગયું છે, થોડું હવે પાછા આવી જાઓ, આપણે કાલે તો આ જ જોવાનું છે. સો વેર ઇઝ માય પ્રેઝન્ટ
સર? ગુજરાતીમાં એક કહેવત છે કે શ્રદ્ધા અને અંધશ્રદ્ધા વચ્ચેની ભેદરેખા બહુ પાતળી છે. એવી રીતે નોન ગુજરાતી પીપલ મે નોટ અન્ડરસ્ટેન્ડ બટ ધી લાઇન the line between rationality and irrationality is also very thin. So you are the best person to Lakshman Rekha apne batavani છે sir. What is Lakshman Rekha?
So these respiratory infections are, you all know, it's very, very common. They are our, I wouldn't say bread and butter, but that they occupy a large chunk of our practice every day in, day out. So this is more of a kind of a brushing up our knowledge about how we should treat our mainly upper respiratory infection that we see in office practice. So I have taken few common upper respiratory infections for discussions, and for that we have a very elite panelist here. My personal introduction, Amruta, Narmada, ભૂલથી અમૃતા બોલી ગયો પણ એટલે she is Amrut, કારણ કે so everywhere you see her in IAP activities, I had the opportunity to work with her in 2019 EB, and I have seen her vibrant way in which she handles everything. Hiralben, I have worked with her on adolescent medicine several times. I have come to Ahmedabad. She has come to Baroda. So a beautiful association in terms of our working with adolescent health. Jay Dirwani, ગંભીર લુકિંગ એકદમ જ, અને ઘણીવાર મારી સાથે એમણે પેનલ ડિસ્કશનમાં પાર્ટ લીધો. વેરી સિન્સિયર પર્સન. સમીરભાઈ અત્ર તત્ર સર્વત્ર સમીર, અત્યારે અમારે એવું કહેવાય છે. હી ઇઝ સો એનર્જેટિક, હી ઇઝ સો ફુલ ઓફ એનર્જી દેટ he takes up responsibility everywhere and he lives up to that. So what happened? Okay, thank you. So first of all, why are we discussing? As I made a background that respiratory infections are our day-to-day practice. So, and most important thing is that all the while when we attend any CMEs or ID programs, we always talk about AMR, antimicrobial resistance, and how we can prevent that, because AMR is going to take a big leap forward in terms of making us very incapable of treating common infection. So every time we talk about any infection, we must focus on how we can prevent antimicrobial resistance. So we'll discuss viral infections, pharyngotonsillitis, acute otitis media, acute bacterial sinusitis, croup, pertussis, and community acquired pneumonia. So this will again be a more of a rapid fire, because we are only 40 minutes and we have a lot of questions about these common conditions. So Narmada, what does rational antimicrobial practice mean to you, and what are the various reasons for irrational use of antimicrobial? Just enumerate, no details.
Rational antibiotic practice is nothing but giving the right antibiotic for the right condition in the right dosage for the appropriate time.
Right.
And be brave enough to step it down when it is not required. What the main reason of using irrational use is 3 things. One is pressure on ourselves. We feel very jittery when we write only paracetamol. We ourselves have a doubt whether we are on the right track. The second thing, pressure from the parents, and sometimes pressure from the industries too.
Right.
So these are the things.
Audience માંથી કોઈને એડ કરવું છે? Because I love audience participation in a panel discussion. I think audience are the experts actually. તો તમારામાંથી કોઈને એડ કરવું હોય તો. Yes. Yes. I think this is the most common. I mean, I've been working in this field of promoting rational therapy, and this is the most common cause for because you are not able to have confidence in yourself. If I don't try an antibiotic, nothing is going to go wrong with my patient. So lack of faith in science, and sometimes we say કે ભાઈ ગાઈડલાઈન તો આવે ને જાય, ઠીક છે બદલાયા કરે છે. No, that's a common excuse that we give કે ગાઈડલાઇન્સ તો બદલાય, એનો શું મિનિંગ છે કે છે કાલે ના પાડી હતી, આજે હા પાડી, આવતીકાલે ના પાડશે. Then lack of confidence, as Digant said, lack of communication skill. No, we know that I don't have to prescribe, but I don't have that confidence of communicating the same science to the patient in the language that he can understand. Fear of patient changing the doctor, કે હું નહીં લખું તો બીજે જતા રહેશે. And a commercial interest, yes, he mentioned about it. And sometimes there is sheer ignorance. They don't know what they are doing. જેમ જીસસ ક્રાઇસ્ટને લટકાઈ દે એમણે કીધું, they don't know what they are doing. એના જેવું હોય છે. Yes, you don't write provisional diagnosis because you are afraid that somebody will read my precision and then મેં લખ્યું છે viral URT અને હું લખું છું antibiotic. So that is why people don't write diagnosis. From panel discussion. That is also very important, and sometimes humor takes over the real messages. I totally agree with you. So what are the commonly seen viral infections? Hiralben, what are the commonly seen? Audience હોશિયાર થઈ ગયું છે આ બાબતમાં. So what are the commonly seen viral infections of RTI? What and how often you use laboratory for making a definitive diagnosis of viral respiratory infections? And how often and which antiviral? તો પહેલા viral નું પતાઈ દઈએ એટલે પછી antibiotic ની વાત.
Okay. Thank you, Satish bhai. Very happy to be on the panel with you. So commonly what we see in pediatric age group is RSV, influenza group of viruses, all the H1N1, H3N2, A, B and para-influenza. We also saw COVID, so coronavirus and recently we are seeing adenovirus more so, and other viruses like rhinovirus and are a little less common.
Right. And how often you come across?
Oh, very common.
So do you use laboratory to make a diagnosis of viral infection?
No, sir. So for routine viral common cough and cold with a stable child and where we are very sure that this is viral, we don't need any laboratory investigations. But for say example, it's a infant less than 3 months or an immunocompromised child, or if I'm suspecting influenza and I want to be sure, then I may ask for influenza test. But if there is an epidemic of flu going on, then I will not test. And so category B and C, I may just start like illness and start oseltamivir.
Right. So the message here is that as we talk about rational therapeutics, there has to be rational diagnostics also. So what she said is very true, that you don't jump to doing PCR or multiplex PCR in all the patients. You select your patient and use it, because throughout the yesterday and today we have been discussing about molecular diagnosis, all that, but you don't have to use it in your office practice. And this he has already answered that we use oseltamivir in epidemic situation. Yes, Digant. એક માઇક ત્યાં આપી રાખવાનું. ના ના, એટલે સંભળાય એટલા માટે, બીજું કોઈ મીનિંગ નથી. Please give him mic so that others can. Yes, please. Please. નહીં, please. આપણી પાસે ટાઈમ ઓછો છે. Okay. If you are enjoying, we don't mind. No, you really wanted to make some comment. Seriously, yes.
Well, as it was not to show my presence, but when
So on my part also. I
when
mean, I didn't mean anything.
when you are treating a case and you are sure about, means you are sure in the sense by your clinical judgment you are sure that you are treating a viral infection, but the case is taking unusual progress.
Yeah.
In that case, definitely you go for say
Agreed.
PCR testing or other testing. A case of influenza, which you know that should get cured by 5 or 6 days, but over 5 or 6 days the child has deteriorated or there is some complication. In that case, definitely it warrants. So the PCRs are not totally useless things. They are useful,
Yes,
but we
yes.
have to use
So
it
that is
judiciously.
what she said, that in given
So here we are
circumstance,
just talking
she
of
may do
routine
it.
OPD.
Any other panelists want to make comment on this? You are all we are on the same page, right? So it's very common to get 3 to 8 colds per year in less than 5 years. Influenza-like illness is something different from common cold when there is more of systemic symptoms like fever, etc. And you don't need to give a lot of things on except for symptomatic treatment. But at the same time, we have to give the warning signs to the patient as to when they have to come back, and we have to use the RT-PCR other multipliers judiciously. Oseltamivir we already discussed. So here we are not discussing the cough, cold, OTC medicines of late, because government has banned the use below 4 years, which I welcome with utmost pleasure. I remember in Ahmedabad only some time back, some years back, I had a presentation on critique on cough, cold medicines, and this was our vision that it should be banned below 4 years. So it's a good thing which has happened. We can discuss it sometime later. Now talking about pharyngitis or follicular tonsillitis, how do you differentiate between viral and bacterial? Is it always possible? Is it practical? And what are the fears on withholding antibiotics? What are the perceived risk? Samir bhai.
Can I change the sequence of answering?
Whichever way you want.
Because the last two answer already we had discussed, so we can just take on the few things which is not taken. What are the perceived risks and the what are the fears on withholding the antibiotic? So perceived risk already losing the patient, what we had already discussed in your first slide.
Specific. These
Specific.
are generic reasons.
Yeah, specifically here again the worsening of the condition, that is one of the fear in these cases. Then diagnostic dilemma always make that thing whether it will be viral or the bacterial, that will be withholding. Thinking the requirement is the prevention of the secondary bacterial infection in viral, that may be the one of the reason. Then patients demand that may be not fulfilled if we not write the antibiotic. That type of the things is also there, and thought that the antibiotic will be required as an add-on medicine in overall. These are the fears what we are
Samir
usually
bhai,
thinking.
this what you are enumerating is basically the fears that we have, but
Yeah.
are they justified?
Yeah,
They
that's
are myths or
absolutely it is a
real?
justifiable that we can, but it is not that thing. It is not pursued things. We have it is definitely we can implement in our practice, but it will be depends on the our own mindset, because we have to differentiate. That is the first answer of that in viral and bacterial. How we can differentiate depends on the our clinical ground. Like the we having some influenza like illnesses and the constitutional symptoms are there, that is more favoring of the viral illnesses. Same thing in the history in the family, that is give the indication of the viral infection.
Right.
Age of the patient, that is also indicator the early age more of the viral, and then followed by the in school going age. Bacterial may be the more common. Something as per the epidemiological presentation, that is also which season it is going and how epidemics is going on in overall in area, that are the more common. And last and not least, the how it is progressing and the how it's onset, that is the acute onset with a acute progress, that will be more favoring the bacterial. So that is a differentiation we can take a look, and we can definitely differentiate the this type of the viral and bacterial case.
Anything other panelists want to add to this?
Sir, you've asked, is it always possible to differentiate viral bacterial? A lot of times it is possible, but there are a lot of times when we are confused whether it is viral or bacterial.
Okay.
So the better way to go about is wait for
And
48
you want to add something which will add to our differentiation between viral and bacterial, apart from what he said, no, family history, epidemics.
Yeah, so
On
multi-system
examination-
involvement. So viral would have other system, like we'll have a GI symptom or coryza rash.
Systemic, it's a
Systemic
widespread
in-
infection.
Yes.
Whereas
And
bacterial tends to localize. That is the basic difference
even
between
on
viral and bacterial.
examination, viral would have a.
So when we are talking about pharyngitis, what will be the difference between a viral infection and
It'll be more of a generalized congested throat, while a bacterial would have exudates. You may see
Yes.
petechia on the palate. There'll be a painful throat. Viral
painful
is
throat can
yeah,
occur in both
yes,
kinds.
yeah.
But you will have
Lymph
lymph nodes,
nodes, lymph
anterior
nodes,
cervical
yes.
lymph nodes.
Yeah.
That anything
So,
else you want to add,
viral-
Narmada?
What I see is more in the older age group, that is above 5 years, if they come associated
Yes.
with, that is more of a bacterial, I would say.
Right.
And if it's a lesser, younger age group associated
You
with
got more
more of
viral. That
a
we
systemic
said.
symptom, it's a viral, I would say.
Right, right. So he
Touchy already
mentioned
said
about
that.
that family history. So once you have a patient with exudates, what can be the differential diagnosis? Do you need to investigate, and when do you investigate? and any role of culture. Dr. Jay.
So majority of the cases of exudative tonsillitis or pharyngitis are because of the group A beta hemolytic streptococcus,
Right.
followed by sometimes EB virus and diphtheria.
Okay.
Early stages of diphtheria, we may not have the pseudomembranous tonsillitis,
Very true.
but simple follicular tonsillitis, which may progress to become pseudomembranous tonsillitis.
So generally you don't investigate, right? Unless the course is unfamiliar, you will go for investigation.
The theory says that even if we are suspecting the group A beta hemolytic streptococcus, you may go for the rapid antigen detection test, but clinically we usually don't
How
go
many
for
of you do a rapid antigen here in this crowd? Have you heard about it? All of you?
Yeah.
None of us are doing, not available, but it is being done somewhere. Narmada, you can throw some
Right,
light.
because in-
Narmada knows about it.
There is Child Test Hospital. There was a study done by SBS, sir, which said that use of rapid antibiotic it rationalize the treatment as well as cut down on the duration of the course of illness when it is going to be group A hemolytic. So that is what we are also having certain labs that are doing it in thing. So now when I see a child who's sick looking and they're definitely having, we go ahead with doing a rapid antigen test. The cost is comparatively less, but the only problem is how to get the correct sample, the cooperation of the child. So because the sample is not right, then it might be just a commensal and you might be hitting this thing. So beyond 3 days, child is very sick looking. If I'm able to get the sample, then rapid antigen test I definitely use.
Right. So in our day-to-day practice, I mean, this session is meant for giving day-to-day practice message. We don't need culture. We don't need rapid antigen. As in our practice, you can make a clinical diagnosis and confidently treat the patient accordingly. So now, once you have made a diagnosis of bacterial tonsillitis, how do you choose an antibiotic for this condition? Is there any issue of dose? What are not the alternatives and why, Narmada?
Yeah. So as we already
You wanted
discussed,
to
if
say
it's a
something?
bacterial
Sorry, you wanted to make some comment? Yes.
it will be positive. So that is why we said I'm not doing it routinely. When the
So-
child is sick looking and the clinical indication is there, you want to decide there is a rash accompanying, then we do it as a thing. That's what I said. It could still be a commensal. Do the clinical indication as a
So
definite thing.
ultimately, it comes
So we're
to
not
that
doing
only.
it as a routine practice. I'm not recommending as a routine practice at
So-
all.
Yes.
There are certain criteria for it.
So somehow the standard treatment guidelines released last year are very adamant on going for the REDT, and if you are
So more, I think the literature comes from Western countries where it's a protocol actually to do it. We have our different resources. We have our different conditions. So we don't have to.
It has got value. That's what I said in
Dr. Amrita,
Western
you want
country.
to say something? Yeah,
Yes,
that is what she said.
Yes. Should touch on the thing.
Okay.
See, the
So,
thing is
but
that West always
Is it
they-
necessary? I mean, that's the question here. So, yes. So for study purpose, for teaching institutes, I think, and protocol-driven systems, that's fine. But otherwise, for this crowd, including myself, no, we don't do, and we
Sir,
don't.
if it is, sorry, sir, if it is available, I would want to do it. I mean,
So follow Amruta's instruction. Go deep, irritate the child, irritate the parents, and then they will go
sir,
back.
this is an older age group of child, and the
Let
child
us
may
move.
cooperate. This is
Let
an older
us
age
move.
group, right? Streptococcal, we are suspecting 5 to 15, so older age group. So it may be possible to do a good collection.
Okay, so Hiral will do it, but I will not do it anyway.
Yes, center score.
Yeah, I have really not taken up that because in our day-to-day practice, we don't take any scorecard. I don't at least take. And we see the patient and we take a call. But before prescribing antibiotic, you should actually think about it. That am I seeing signs of bacterial infection or can I wait or not? While waiting, no, we didn't talk about rheumatic fever. That is not seen nowadays, but it's a theoretical threat that if you do not treat, your child may end up with rheumatic fever. But there the window is very, very good actually. 9 days. You can delay the treatment up to 9 days. Nothing will happen. Sorry?
No, it's not.
Yes, I heard about it. I read about it, but we don't do it.
very, very clear.
So,
It is very clear in the guidelines, also in standard treatment guidelines, though they have given RADT, they have clearly differentiated the children into well child and the sick child.
Right.
Only in a case of a sick child, when the clinical suspicion is there and you are suspecting more of a bacterial pharyngitis, they have
So we
recommended
move on. We have
RA.
diagnosed follicular tonsillitis or pharyngitis. So Narmada, now
The antibiotic of choice, everybody knows it's amoxicillin only. The choice comes for us is whether to go for the routine normal dosage of 40 to 50 milligram or with the recent trend in the commercial thing to go up for the higher dosage. The recommendations are very clear that we still have sensitivity. We are suspecting, as I said, strep pneumoniae and H influenza. More of with the vaccination strep pneumoniae, it is definitely sensitive. There are CMC value study has clearly differentiated the strain of to be sensitive to the amoxicillin. So go at 40 to 50 milligram per kg. They have clearly said only the meningitic strain is showing resistant to ceftriaxone. So in this condition, stick to 40 to 50 milligram per kg. You will be definitely going through this. So again, it depends on if you are sure about the strep pharyngitis, complete the dosage as we already said to about 10 days. You have to complete it. So
10
that is
days
the
is
difference.
compulsory.
Yes.
Right.
So the normal dosage, the routine recommended dosage of amoxicillin in the recommended duration, definitely we would give.
Right. So what are other organisms here that you want to treat apart from gas?
H flu, H influenza,
okay.
Moraxilla catarrhalis,
Okay.
all of
So
them
there
also will
there
respond
the strategy might change.
Change.
But as far as gas
to
is
5 days,
concerned,
10 days.
see, I have put a little bit of summary here that we get GABHS, it's a commonest organism, then Streptococcus pneumoniae, then H influenza, and occasionally this other organism. So here the basis is that GABHS, that is your gas, is universally sensitive to penicillin. So you don't have to think again about changing antibiotic. Go for amoxicillin, that is penicillin. As pneumonia develops resistance aminopenicillin by altering PBP, that is penicillin binding proteins, and not by producing beta lactam. So sometimes this is a general analysis of how we should choose an antibiotic. So increasing the dose is the answer, and not adding beta lactamase to that. I mean the combination of BLI. And India, there is no significant DRSP, as she said, and macrolide resistance is 30 to 40%. So when we talk about treating a URTI, don't use azithromycin because the resistance is very high, 30-40%. And H influenza, if you are thinking about it, it does produce beta lactamase. So here BLI is justified.
So, one more thing regarding if it is recurrent, even though we have to treat with the amoxicillin only.
Yeah, we are coming to that. We are coming
Yeah.
to that.
So one more thing is the vaccination, the history of vaccination, sick looking
Yes.
child, that will again determine.
Again,
So
now
an
because it has
unvaccinated
become
child-
universal, we should inquire
Yes.
about vaccination. Very good. So these are some of the viral EBV we have already discussed, and recently, there was a huge surge of adenovirus infection, which used to present with similar clinical situation. Why to treat? Because there are non-suppurative complications like rheumatic fever. So to prevent that, but as I said, there is a window, and there can be a suppurative complication like peritonsillar abscess. And C. diphtheria is very uncommon, but we have to keep in mind. And we see in Gujarat also some of the districts do report diphtheria. Culture only in selected cases and clinical picture and review for help. Choice of antibiotic, as he said, amoxicillin, no issue of dose, prevention of rheumatic fever 9 days. And these are some of the alternatives. If your patient is allergic to penicillin, then you have this other options. And in the morning, Dr. Narmada had already presented a whole good table about doses, etc. We are not going to detail. So now we come to recurrent part. Hiral, what are the causes of recurrent tonsillitis, and when do you refer to ENT surgeon?
So, recurrent tonsillitis means these are repeated episodes with normal intermittent period when the
Right.
child is normal. It's
Right.
not a partially treated or a relapse. So, recurrent tonsillitis, if we look at it, the one common cause is poor economic household and overcrowding and school scenario. The other thing is structural problems. So, if there are enlarged adenoids, or if the tonsils are extremely large, like grade 3, grade 4 tonsil, like the kissing tonsils. So these large tonsils, a lot of bacteria and food particles, they get engoed in the crevices of the tonsils, and which leads to the carrier bacteria and bacterial growth. And there's also this theory of genetic susceptibility to recurrent tonsillitis, which has been noted in a few families. So these families, they produce less antibody to streptococcal toxin. So recurrent tonsillitis is also one of that. So a biofilm is formed on the tonsil. So these are some causes. And when will I refer to an ENT surgeon is when I want some intervention to be done for the recurrent tonsillitis. So which is like we have criteria. So if there are more than 7 episodes of recurrent tonsillitis in a year, They say they should be culture proven. So now, if you're not doing culture, I don't know. Then, or more than 5 episodes in 2 years, or more than 3 episodes in 3 years, then that's an indication for surgery. Apart from that, we'll definitely refer a child who has obstructive symptoms like obstructive sleep apnea, dysphagia, poor growth, missing too much of school. And also, one of the indication, though not common, is in FAPA, periodic fever and recurrent. So these kids benefit from tonsillectomy.
Right. So, but by and large, in our day-to-day practice for tonsillitis, we differ from referring them to ENT surgeon.
So two
And
things I
they
wanted
also
to
have learned. Sorry.
Two things I wanted to add, sir.
Yes.
One is the smoking, in-house smoking episodes. That is definitely there, and especially when they're taken care by the grandparents. And in our places, they are the BD workers are there. The parents usually go out. The grandparents are the smokers here, so that has to be taken history. And the other, bottle feeding. The third one is definitely ask for the question of refer to the ENT surgeon early for this condition. Why? Because they will have otitis media
We are coming
associated
to that.
chronic.
We are
That is
coming
right.
to that. So thank you for that beautiful coverage of why you should not be referring or why when you should be referring to ENT. One of the reasons for recurrent tonsillitis or any other infection is inadequate doses, inadequate duration. How many of us actually write for 10 days? So I was just thinking aloud, and some of you already raised your hand. That very few, 30% of the crowd I could see the raised hand who are prescribing for 10 days. Many of the precision I see 1 bottle, 2 bottle, and 7.5 ml 3 times. So that comes to your how you are ensuring. Tushar. Since you have made a comment, listen to me. So whether they take it or not is a very different issue altogether. It comes to management, how you actually ensure adherence to your treatment in all aspects, not only in URT, anywhere. So we don't talk about adherence because of lack of our communication or the way we explain. But are we writing for 10 days or not? That is important. Okay. So inadequate duration and inadequate dose is also an important cause for recurrent infection. So now we come to acute otitis media. So I'm not presenting any cases because there is no point in wasting time on, okay, 6-month-old child came with fever, he was meddling with his ear and all. So we straight away take cases only, the scenario only. When do you administer an antibiotic upfront, and when can you be justified in withholding an antibiotic? Which antibiotic you use? Why do you use that? When do you change the antibiotic? Any issues with the doses? These are all kind of question that arise in our mind when we deal with otitis media. So, Dr. Jay.
So treatment for acute otitis media is basically designed on the age, laterality, and severity of the symptoms. So if the age is less than 6 months, even on the presumed diagnosis of acute otitis media, even if it is unilateral, we can start the antibiotic upfront,
Right.
because of the fear of early complications. When the age is between 6 months to 2 years, if this disease is bilateral, then we can start with the antibiotics, or even if it is unilateral but severe disease, then we can start with the antibiotics. Above 2 years, we can withhold the antibiotics for at least 48 to 72 hours and keep in watchful observation unless there is a very severe disease.
Very good. So, how many of you use this guideline that about 2 years you wait and watch? I think we should all be doing that. There is no big harm, and very good criteria are already put up here. So before we actually talk about management, we should be clear about this terminology also, that there are 3 kinds of things that we deal with. OME, that is otitis media with effusion, which is fluid in the middle ear, 8 weeks in absence of sign symptom of acute infection. But we often miss this because most of us now are keeping an otoscope, but maybe we are all not using it, or maybe if we are using it, we are not able to visualize the tympanic membrane well. So we have to upgrade our instruments in such a way that we can actually see this effusion, because it's in Western countries it is very common, and they treat it very well with grommet insertion. There is no reason why we should not be getting. So many a times when I refer my patient to a ENT surgeon, he would come up with this OME diagnosis. So keep this in mind, that we are talking about AOM. We should always have that OME also in mind. And it is one of the commonest form of otitis media, more common than acute otitis media. And it usually follows a viral rhinosinusitis. AOM, how do you make a diagnosis? There is moderate to severe bulging of tympanic membrane, or if there is a mild tympanic membrane bulging, but with recent onset of ear pain and erythema of the tympanic membrane, or new onset of otorrhea, then you label this as acute otitis media. CSOM, as you know, chronic suppurative otitis, discharge which is lasting for more than 2 to 6 weeks. More often we see this in immunocompromised patients or malnourished children. The causative organisms are both viral and bacterial. Usually viral followed by bacterial. Viral are RSV influenza. Bacteria, as we all know, is Streptococcus pneumoniae, H. influenza, and Moraxella. So as Jai was describing, otorrhea, severe disease. Now, what is severe disease? Severe disease is when fever is more than 39 degrees centigrade, severe otalgia, and otalgia more than lasting for more than 2 days. And if there is a bilateral AOM in less than 2 years, AOM less than 6, he very well said that. About 2 years, it's more likely to resolve spontaneously. So defer antibiotics in those who are more than 2 years with non-severe AOM. Severe AOM with these three things, fever, severe otalgia, you give upfront antibiotic. But if it's not severe, you can withhold the antibiotic about 2 years of age. 6 to 24 months, as he said, with non-severe unilateral AOM, you can withhold. And watchful waiting means you give only supportive treatment with PCM ibuprofen for 48 to 72 hours. Now, these guidelines are there in the recent book on rational antibiotic practices by IAP. But what they have mentioned is that now AAP is liberal about using antimicrobials with individual discretion. And in OME, you don't have to give any antibiotic. This is very important. So OME, I am not discussing in detail. It's a subject by itself where you have to refer to the patient to ENT surgeon. You are mentioning about otitis media, and if necessary, grommet insertion should be done. Somehow in India, this is not practiced much because we don't refer the patient very frequently to them. We do not have pediatric ENT surgeons. That's a big problem here because they don't understand well how to deal with the kids when they are crying. And when they talk about grommet insertion, parents are usually very scared. So we as pediatricians should also give a message to the parent that grommet insertion is, yes, I am keeping in mind. So grommet insertion is not harmful, it is good for the child. Hearing testing should be done in all these children who are suspected to have. Yes, Chetan. Yeah,
It is.
this. Okay,
It is our.
thank you, Chetan, for sharing this information. This same instrument was brought by Dr. Jagdish Chinnappa couple of years back in WebCon. He had demonstrated it. I have seen it. But when it comes to examining a child, you holding that instrument and looking at your mobile, doing a because it has to be focused here in the ear. But then we have not anesthetized the child. No, that's the problem. Anyway, so
Sir, it's.
so, so Chetan Bhai will give us more experience with some study of 100 cases or so.
Sorry, sir, it
so,
is.
Yes, wax is a big problem. So in one of the conferences, the faculty was talking about AOM and using
Sir, it
optional.
is our part of our smart medical practice. With it is a part of that instrument. It is there.
Okay, so you all attend the smart medical practice workshop also in the coming days. It's going to be held in Cochin also, right?
Not it.
Not it. Okay, so it will come to your town later on. So in one of the conferences, the speaker asked, when we see in the ophthalmoscope, what do we see? Majority have said that it is wax that we see. So wax is a problem. So we need to learn about how to clean the wax also. We'll not go into that detail. So when do you administer antibiotic upfront? That we have done. And which antibiotic, Dr. J?
So as you mentioned, the most common causative organisms are S. pneumonia, H. influenza, and Moraxella catarrhalis. So
Right.
the choice of antibiotic will be amoxicillin. First choice.
Beyond that,
Beyond that, if the patient does not improve in next 48 to 72 hours, then we can go for adding clavulanic acid, or we can go for the second generation cephalosporins like cefuroxime or cefuroxime.
so if you are persistent or recurrent AOM, or if you have previous treatment with antibiotic, which happens very often, patient has gone to a family physician or other pediatrician, some antibiotic or other is given, and if there is a concurrent purulent conjunctivitis, then you are justified in using amoxiclav rather than amoxicillin. And there are, of course, these are all the alternatives. And interestingly, I read about azithromycin that it can be given for 1 day, 3 day, and 5 day, depending on what doses you give. 30 milligram per kg per day, 1 dose, 20 milligram per kg per day, 1 dose, or 10 milligram per kg for 5 days. And duration, there is a lot of uncertainty about it, but the general consensus is that you give it for 10 days, at least below 2 years. 2 to 5 years you give for 7 days, and more than 5 days you can give for 5 days. So what complication can happen, and how do you approach recurrent otitis media? When do you refer to ENT surgeon?
Complication usually we divide into the intratemporal, means inside the ear, then the intracranial or the systematic. In the intratemporal, we having a chances of this something is like we can say chronic otitis media, then perforation. There is a chances of the hearing loss, mastoiditis. That is one of the complication temporal also. Intracranial, we having either of the meningitis, encephalitis, any type of the abscesses and the sinus thrombosis. Systematic, we having a bacteremia, septis, arthritis, and the bacterial and endocarditis. That can be the complications are there. How do you approach to it? That will be the indicated mainly related with the immediate management of the acute episode, followed by the proper diagnostic workup. What will be the including that diagnostic workup means why it's present as a persistent. Then second thing, what are the other complications associated with, and the right time referring to the ENT surgeon for the management purpose. And that management include the helping in the diagnosis purpose also, and the surgical management purpose, like what we have discussed, the grommet insertion or some surgical intervention that is leading to the problem.
Anything you want to add? Any other panelist?
The only thing is the allergy component of this. When in the case of a
So
recurrent
we have to
otitis
take care of the allergic
that
component.
is definitely
In our practice, what I have seen personally is that allergic rhinitis is very, very,
very
common.
common.
We often fail to diagnose it and treat it well. Treat it well in terms of controller therapy as we do it in asthma. So intranasal steroid is the answer to recurrent, this allergic rhinitis. It will to a great extent help in preventing upper respiratory, upper airway obstruction, and then will lead to less occurrence of otitis media as well as tonsillitis.
Because the biofilm concept is not only for persistent bacterial bronchitis, it is also very much for otitis media with effusion.
Right.
So we do have that component. So allergy and biofilm.
Right.
Can you please wind up
Only-
in 5 minutes?
Yes.
Only thing is the
How many minutes you said?
5 minutes.
Audience ની ડિમાન્ડ વધારે હતી એટલે હું ધીમો ગયો હતો. કઈ નહીં.
Chetanbhai and Manishbhai
only thing is the
submit. I'm
effusion
not
may
aware.
remain persistent, but it's not an indication of the any surgical intervention.
Right, right. So now we come to sinusitis. How many of you write sinusitis in your diagnosis? And how often in compared to your URI and all that? So there is acute rhinosinusitis, what we call as common cold. What we are trying to focus now is on acute bacterial sinusitis. So Narmada, when do you suspect sinusitis? Any importance of duration of symptoms? How do we categorize sinusitis? What are the risk factors for getting sinusitis? And do you need to investigate, and what investigation?
Yes, sir. Again, the same factors only, sir. The same severe infection, persistent and recurrent infection. Child has got a fever, in between intermittent it has not been there, and suddenly recurs again with a severe manifestation, then I'll suspect. Persistent symptoms, that is the fever and the upper respiratory signs persisting along with a headache, persisting beyond
So
72
beyond
hours.
how many days you would
3 to 5 days, I would definitely suspect. And it is very severe also for the thing, then we would
Okay.
suspect. And the one more thing is, in a little older child, definitely headache above 8 or 9 years. But below that, we need to have a high index of suspicion.
Anything
And-
about discharge, kind of quality of discharge that you get?
That is less than 5 years or 7 years. I don't give much importance to it, but beyond the older age, definitely we would give importance to
So
that.
do you
also.
give any importance to yellow discharge
No,
in diagnosing sinusitis?
no.
So often we sort of infer that yellow discharge is purulent
exactly.
discharge, so we have to give no. Even in viral infection, you can get purulent discharge initially. If it goes beyond certain time, no, then you start suspecting sinusitis.
Yeah.
You want to add something? Yes.
Post-nasal drip.
Post-nasal drip.
Post-nasal drip.
Post-nasal drip. Yes. Yes. When you examine, there is a post-nasal.
It will be there. And so these are the conditions we would suspect. Again, the duration, the causes for the recurrent sinusitis again are the same, which would be for other respiratory like overcrowding, bottle feeding, and this allergic component, smoking. Definitely.
So all are these are common with
Common thing.
pharyngitis as well as
Yeah, and
sinusitis.
anyway, laterality, that is, you have sinusitis, you have this pharyngitis, lateral involvement more, 10 days to 14 days is the treatment there.
Right. And what about investigation? Do you take a PNS X-ray?
Not routinely, definitely not
routinely,
routinely.
yes.
But if the symptoms are very severe, slightly older child, we have
Especially in
other-
older children,
older
adolescents, yes.
Others component of adenotonsillitis, when there is an obstructive OSA component, I would get an ENT involved as quickly as possible, as well as do the investigation for
So
sinusitis.
these things do go together, no? Your allergic rhinitis, your OSA, your deviated nasal septum in adolescent patients. So all these things should be taken together, and we have to address all those issues.
We have to
So
think, we have to think for the foreign body also.
Yeah, the sudden.
Yes, as a differential diagnosis of unilateral nasal
Nasal
discharge.
sinus.
Yes. So inflammation of mucosal lining of paranasal sinus is less than 30 days duration. Beyond that, you call it chronic,
That is the chronic
bacterial
one.
sinusitis. It's both viral and bacterial, symptom lasting for more than 10 days. There is a double sickening. There is a terminology called double sickening, whereby you see some improvement in the viral cold, and again the child starts worsening that you mentioned. And acute onset of high gravity that she has already talked about. These are the organisms. The complications are again meningitis, cavernous sinus thrombosis, orbital sinusitis, and risk factors are already she has enumerated. So, what is the choice of antibiotic, and what should be the duration?
Yeah. So as for the other things, amoxicillin is the first choice of antibiotic, and dosage we would start with the routine 50 mg per kilogram, and duration is 10 to 14 days or at least 7 days after the resolution of symptoms.
So here there is no confusion. Once you make a diagnosis of acute bacterial sinusitis, make it a point that you give for enough duration. When do you refer to ENT surgeon, and do you call back the patient and review the precision? There is an answer in this question actually.
When we are dealing with a chronic sinusitis lasting for more than 3 months, or when the acute or subacute sinusitis not responding to the proper line of treatment with the proper appropriate choice of antibiotic given for the appropriate duration and appropriate dosage, and when we are expecting or there is impending or manifested complications like severe frontal headache or neurological symptoms or periorbital cellulitis, in such cases we have to refer to the ENT surgeons.
Right. So the problem with ENT surgeons, as we heard, we talked about earlier, is that they are not pediatric ENT surgeons. We don't have them. So often their antibiotic choices are off the mark. Their dosages are very, very pathetic, I would say. And they prescribe a lot of this decongestant, antihistaminics, nasal drops and everything.
Steroids
So
are the
you-
favorite.
The best
for
way is
ENT.
refer to a junior
steroid
ENT
also.
surgeon, get the diagnosis, ask them to come back to you.
Yes, yes. So I always call the patient કે ભાઈ અહીં આવીને જોજો પછી બધું ચાલુ કરજો.
So, but
Older children they advise nasal wash. I think that's an approved
Nasal
therapy.
irritation.
That now it is with corona it came as a niti or neti or something.
Yeah, yeah.
But it's an approved therapy even before corona. So it is a wash actually basically. So
so
that's
here,
fine.
sir, here we are referring the patient to the ENT surgeon for some surgical intervention. So
Yes, but then they
whether
don't
I'm
think
needed
before
or not,
inking,
yeah.
like
But
we
yeah,
do.
we do call them back for the proper choice of antibiotic and proper dosage and duration. Yeah. we
Yes,
call
yes. You have already mentioned that. So we now quickly go to 2-3 conditions. So short answer, we'll finish in time, 5 minutes. Do you see pertussis in your practice? Do you prescribe antibiotic and why? Which? Samir.
Yes, definitely we all see pertussis in our regular practice. And the typical presentation of that whooping, we never miss that type of the thing.
Unfortunately, we don't see that typical. We see prolonged cough. Right. Yeah.
But we usually see that, then we can at least diagnose that thing. And if we diagnose early, antibiotic is always the ideal way to get the maximum response with that antibiotic. Second important thing, if we start late, it may prevent to the recurrence also, and the prevention to the spread to the other people also.
So
The
more
prophylaxis-
important than treating the, no, because usually we don't make a diagnosis in 4-5 days. It's usually after the cough gets prolonged. So the idea is to prevent the spread of the, the infection to the community. That's why we give. And which antibiotic we prefer?
preferably is the macrolide, and
Okay, fine.
that azithromycin is the preferred.
Right. Now, group, can you treat on OPD basis, and how and role of antibiotic?
Again, it depends on the condition of the patient, sir. So if
Exactly.
it's a very
how do you
mild,
categorize a patient with croup?
yeah, in group, if the patient makes me to call them into my office, if I'm able to hear the sound, then it is really very severe. Or see the respiratory distress, saturation, and then irritability, all that will decide. If the child is otherwise okay, and child sitting on the mother's lap and crying, when they cry, I hear the whoop, then it is a mild variety.
Right.
So this is the only category I can put it on the OPD basis.
Right.
The other category I would like to observe. But even in those OPD category, I clearly tell them when the whoop becomes more or child is not feeding, the respiratory distress is more, ask them to come back even in the night times.
So what do you do in the OPD?
So usually if I'm going to treat them as a OPD basis, give a dosage of steroids alone, sir. Don't
Okay.
give for the adrenaline. But if it's a moderate to severe category, if I'm going to observe them, then adrenaline nebulization followed on with the steroid also, because the post complication, I have to treat it.
Right.
Observe them minimum for 12 to 24 hours, because there will be a recurrent at the end of 12 hours. More than 2 dosage of adrenaline has not been required in the practice.
Right.
there.
And what kind of response you expect when you give steroid or adrenaline?
So
Usually it is dramatic.
it is
Usually
very
it is
dramatic. The sound
very dramatic.
immediately comes down.
So
It's
it's,
one of the condition the parents feel that you're a god. I
Yeah,
think more
so-
than that.
so that's about croup. And shall we take up 3-4 questions? Rapid question. So how often do you treat pneumonia in OPD basis? Can you differentiate between viral and bacterial? And does it affect your decision? Quick.
OPD basis, sir, as she's already said, sick child, respiratory distress, saturation, all of that. So they'll go to the hospital. Pneumonia less than 3 months will go to the hospital. So I will treat a child on OPD basis who is stable, feeding well.
Can you differentiate between? Do you make an attempt to see whether it's a viral or bacterial? And does it make a difference in our practice?
So, sir, if this is bronchiolitis kind of a viral, it will make a difference if it is bronchiolitis.
We
I
are
will
talking
not
about
give an-
community acquired
So
pneumonia.
community acquired pneumonia, if I'm seeing a pneumonia on X-ray, is that what you're asking, sir? A consolidation you are asking?
Yes,
Then-
even if you are seeing on X-ray.
Yeah, so if I'm seeing a
Usually
consolidation,
X-ray is
I'm
not
going-
advised actually. In theoretically, no,
So
you,
in-
don't, you make a clinical
So
diagnosis.
clinically, sir, if I have bilateral signs and I have crepitations with wheezing, I will
Suppose you are
suspect
treated
viral.
on OPD basis, what precaution will you take?
I will ask the child to come back, follow up in 48 hours to look for improvement or worsening.
Anybody
And-
wants to add to this viral versus
Yeah, no,
bacterial?
this
Yes.
chest X-ray you
Yes.
said no, sir. Again, it is the community oriented or it's a one-to-one practice. Let us be very frank that when we are having a child who's having a respiratory difficulty, fever beyond 3 months, 3 days and sick, I would definitely go for an X-ray, just X-ray.
No, I'm not talking about X-ray. I'm talking, would you like to differentiate? Suppose it's the OPD patient who has come with little tachypnea, fever, some chest sign, and you make a clinical diagnosis, community acquired pneumonia, right?
Yes, sir.
Then will it make a difference whether it's bacterial or viral? I mean, in our day-to-day practice, we talk about rational antimicrobial practices. The question is very simple.
sir,
I am
it will
asking
be-
the audience,
Sir,
how
depends.
many of you don't give antibiotic to a patient who is diagnosed as CAP, probably viral? So that's the message. Here is one condition where you are justified in giving antibiotic, empirical antibiotic. That was the message. I wanted
Absolutely.
to say. And so it doesn't affect our decision, but of course, when the child progresses badly, you investigate and all that. But it is 10 days. 10 days. Okay. So how do you decide the choice of antibiotic quickly, Dr. Jay?
The choice of antibiotic basically depends on the age of the child and the severity of the symptoms. Below the 3 months of age, the child goes to the hospital straightway for the treatment. Between 3 months to 5 years, if it is a mild pneumonia, which is defined as the fever, rapid breathing, with or without the presence of chest restrictions, this can be treated home-based treatment with the oral antibiotics. The first choice of antibiotics in such cases again amoxicillin. Second line of antibiotic is amoxiclav, cefpodoxime or cefuroxime. And if we are suspecting Staph aureus, then we can go for the linezolid or oral
We
clindamycin.
will not go into those details which are, we are talking about office practice. So, as he very rightly said, mainly you have to look at the age of the child and other background of the child. So, depending on that, you make a choice of antibiotic. And what are the cautions one need to exercise while treating community acquired in office practice? Samir bhai?
Hello.
You have made a diagnosis, you have decided to treat, or parents have decided. Sometimes they don't agree to for your indoor admission. And often to our big surprise, they do well also on our OPD treatment. Many a times it happens that they don't get admitted and we prescribe antibiotic, either amoxicillin or amoxicillin, they do well. So when you are agreeing to treat on OPD basis, what precaution, what red flag signs you will tell the parent? That's what
That's the thing. One thing, if we start the treatment, what accurately that Tushar Bhai says, they start the antibiotic in the right dosage. Second is the right duration. Along with the supportive management, that is a very, very important nutrition, because we are treating in OPD basis. So patients should know what are the precautions and nutrition they have to take
So
at home.
red flags. What are the red flags?
Red flags and means the deterioration of the symptoms that increase the respiratory rate and the looks like a problematic thing. We have to check, and proper regular follow-up is very important. Sometimes including the isolation and importance of the vaccination also we have to keep that.
Thank you. Thank you. So to summarize, URTIs are clinically possible to differentiate between viral and bacterial. You can be very confident about not giving an antibiotic on day 1 or day 2 or day 3 of fever. There are if no danger signs, you can wait. And community acquired pneumonia empirical antibiotics are justified. Antivirals in epidemiological setting, like say ILI illness is where no epidemic of flu is going on, influenza, and you can give oseltamivir. And choice of antibiotic depend on suspected common pathogen. You have to have that in mind, the age in which these organisms are common. Accordingly, you decide, and severity. So talk and think before you ink. So think before ink is very well known. I have added talk. It means you need to communicate well with your parents or your patients. Then only they will agree to your suggestion of withholding the antibiotic. So the main message was to be confident about not giving an antibiotic in our day-to-day. એટલે કાલે તમે 10 પેશન્ટ જોશો URTI નાથી, એમાંથી કેટલી એન્ટીબાયોટિક કેટલા જણને લખવી પડશે? હું 10% લખું છું, એટલે એક જણને. ઓહો, બધા એક વાળા, કોઈ બે વાળું કોઈ નથી? 3 વાળું, 4 વાળું, 2.
કેવા પેશન્ટ આવે છે?
Thank you all. Thank you. I thank my panelists. I mean, brilliant job they have done for a very common topic, but often we get confused with this some of the guidelines. So thank you all panelists. Thank you.